Our research was to do a comparative effectiveness study of 6,961 veterans who were treated in routine medical practice. We wanted to compare the effectiveness of ledepasvir, sofosbuvir, with or without ribavirin, to ombidisvir, paritaprevir, ritonavir, and dasabuvir, with or without ribavirin, and see how those drugs perform in the real world. We know in clinical trials the SVR rates are incredibly high, but we also know that often when drugs get used in the real world, then the clinical effectiveness is not nearly as high as the clinical efficacy. We actually tried to include as many people as possible. The inclusion criteria were you had to have started treatment with ledepasvir, sofosbuvir, with or without ribavirin, or ombidisvir, paritaprevir, ritonavir, dasabuvir, with or without ribavirin. You had to have started treatment by March 31st of 2015. You had to have stopped treatment by July 14th of 2015, and then you had to have a day supply that was 91 days or less, because we were trying to capture patients who either got 8 weeks or 12 weeks of treatment. This is an observational intent to treat cohort analysis. So we amassed this cohort of patients who got treated in the real world, and then we follow them to see what their virologic outcomes were. SVR was defined as having a HCV RNA less than the limit of quantification, and after the end of treatment, with at least one test more than 10 weeks after the end of treatment. There were several critical findings. One was just in general that the SVR rates were incredibly high, and so the clinical effectiveness was actually nearly as high as the clinical efficacy which we'd seen in clinical trials. And for us in VA in particular, that was really remarkable. In the past, the medications have never worked quite as well in the real world as they do in the clinical trials. And this is the first time that the clinical effectiveness nearly matches the incredibly high rates in the clinical trials. The second sort of point of note is I think that in many of the subgroups that we analyzed, again, subgroups that have previously predicted low response, so cirrhotics and treatment experienced and people with diabetes or people with HIV co-infection, many of those factors that had previously predicted poor response, many of them no longer predict poor response. The final main finding was we do multivariate models that then include numerous of these factors, and what we find is in intent to treat multivariate models, the factors that independently and negatively predict SVR are African American race, BMI of 30 or more, a FIB4 over 3.25, and then ombidisvir, paritaprevir, ritonavir, dasabuvir, and ribavirin. If you compare that to the patients who got ledepasvir, sofosbuvir, that's a negative predictor of SVR. If you repeat the models and limit it to patients who got 12 weeks, then in fact the only two factors that remain as significant negative independent predictors are BMI of 30 or more, or a FIB4 over 3.25. So again, patients who are overweight or patients who have more advanced liver disease still have significantly reduced odds of SVR. Interestingly, in the models limited to 12 weeks, then African American race no longer predicts reduced odds of SVR, and OPRD plus ribavirin also no longer predicts reduced odds of SVR, sort of indicating that those factors are probably largely related to early discontinuation rates, so that if you can get people to take the full 12 weeks of treatment, then those factors don't matter. In this particular trial, we don't actually assess for side effects because this is administrative data, and given the size of the cohort, we can't actually assess for SVR or for side effects. I can say in general, even though this was the real world, our treatment completion rates are incredibly high. Again, not quite as high as in the clinical trials, because treatment completion is never quite as high in the real world as in the clinical trials, but if people were having side effects, they weren't enough to cause sort of early treatment discontinuations. This area of research is important for sort of two reasons. One is there is, of course, a large population of people who have hepatitis C in the U.S. There's someplace between 2 and 4 million people. We can argue about how many. These medications, the direct-acting antivirals, have been sort of a fundamental shift in the effectiveness of medications. And I think particularly because in the past there have been issues that the clinical trials data have not translated to clinical effectiveness, and people are hesitant about paying for medications if they don't work in the real world, it's incredibly important to document that indeed in the real world, outside of clinical trials, these medications work incredibly well. The main way is that it will change the way doctors treat their patients. And I think we were already there. There was already great enthusiasm for these medications, and I think that this just confirms that enthusiasm, that indeed in the real world they work incredibly well, and so doctors should be trying to get their patients on these medications. I think it also reinforces what, again, we all know, is that adherence matters, and that for patients, that it really, if you can get patients to complete a full 12 weeks of treatment, the medications are incredibly effective, but you have to make sure that people get 12 weeks of medications. The other important issues to keep in mind is that screening still matters, right? The only way we can get people treated is we actually have to identify people. VA does an incredibly good job of screening for hepatitis C, but out in the real world, screening for hepatitis C potentially not done as well. And so while these drugs are amazing, the only way that people are going to get access to them is if we actually know that they have hepatitis C. Additionally, today I was at 2 talks, both demonstrating some difficulties with people getting access because of insurance reasons. And so I think this type of data helps on that front, that if we can really demonstrate to the insurance companies that these drugs are incredibly effective, then it may make it easier for patients to actually get them. They are in fact in the works. We have assembled expanded the cohort and now have a cohort of 21,000 people who have been treated by these medication regimens, and we're assessing outcomes in those 21,000 to see if the factors that we've identified in 7,000 people actually play out when you look at a larger cohort.